that the presenter is Professor Diana Sarfati, but she'll be joined by Dr. Dingle Spence. So it will be, in a sense, a two-part presentation. And in fact, further to that, we also have a brief presentation from the President or Chairperson of the Caribbean Association for Oncology and Hematology. This is Dr. Marissa Nimrod. So we're hoping to tie all of those things up and still stay as close as possible to the time limit that we've been set. I expect that it will go a bit beyond that, and we're already starting a little late. Of course, you all have been here all week, so you know the procedure in terms of questions. At the end of the presentations, we'll invite questions, and when you come up to the mic, you say your name and who you're affiliated with, or the organization that you're representing. So, Professor Sarfati is from New Zealand, and she's coordinating a Lancet Commission on Cancer Control in small island developing states. So her presentation will be overview related to that. And Dr. Spence is based in the Caribbean, in fact is a classmate of mine, and she'll be focusing specifically on the issues of cancer control in the Caribbean. So let's welcome Professor Diana Sarfati.
Thank you so much. So yes, I'm from Wellington, New Zealand, so quite a long way away. Apparently New Zealand is playing West Indies in cricket today, so I'm told. Maybe there's a few people watching that, I don't know. Thank you very much for coming this morning, this early on a Saturday morning. So I'm a public health physician and cancer control specialist, and indeed here to talk about cancer control in small island developing states. I don't know what's happening there. Is there one? Hopefully we can get rid of that. IT guys, is that? Hopefully they'll get rid of that. Anyway, so just a little bit of background. Oh, it's fine on that side. Oh, good. A little bit of background. This presentation, as you've heard, is going to be in two parts. I'm going to be talking about the Small Island Developing State Cancer series that the Lancet has commissioned, and also looking at some of the key challenges across the cancer control continuum in the Caribbean. I'm from here, which is not very close to the Caribbean, but in the Pacific. And obviously there's a lot of small island developing states in that region as well. And Dingle Spence has been leading the work relating to this series from the Caribbean point of view. So she comes from close at home. So she's going to be talking particularly about some examples of innovative practice from the region, and also looking at where to next. So just a bit of background about the Lancet Oncology series. It has included in the end 65 authors from 27 countries, so major undertaking. It's a bit of a mixed blessing being asked to lead one of these things, because it doesn't come with any resource. So it's just everybody who's involved has donated their time really because they consider cancer control such an important issue. And what we've ended up with in this series is 5 separate papers. 2 of those relate to the Caribbean and 2 to the Pacific region. So each of those pairs of paper, one of them is an overview of cancer control in that region, identifying the challenges and the progress, and then the other paper focuses specifically on examples of good or innovative practice from the region. So these papers are not yet publicly available. They are going to be formally launched at the Ministers of Health meeting in the Pacific the first week of August, and we're hoping to do a launch at the Caribbean Ministers of Health meeting in September. That has yet to be confirmed, so if anybody's got strings that they can pull to make sure that happens, that would be awesome. We're still working on that. But the first launch will definitely occur at the Ministers of Health meeting in Tahiti, and at that point the papers will be publicly available, so a lot more detail than what we're going to present to you today. Just by way of background, in terms of Lancet series and Lancet commissions, there's been a number of them in relation to cancer, and they tend to fall into two categories. One relates to sort of an element of the cancer control continuum, something like radiotherapy or surgery, and others look at particular regions. And you can see there's been one on Latin America and the Caribbean. There's one there on Russia, China, and India. And of course, there's also a lot of reports from various international organisations on cancer control in low and middle income countries. But none of those really identify the very specific issues that are facing small island developing states. And even when you've got something like the Latin American and Caribbean series, the bigger countries tend to dominate in terms of the issues that are identified. So this series is specifically looking at the particular issues facing small island developing states. I wanted this series to be very much regionally led, so the voices of the people working in the regions, solutions focused, and also, and really importantly, actually getting cancer on the leaders' agenda, because in small island developing states, cancer tends not to be on the leaders of health's agenda, or not very high up. So you guys will know all of this stuff in terms of some of the key issues facing small island developing states in general. First of all, of course, small island developing states are massively diverse. There's massively diverse countries that are included in that grouping. But they do share some common characteristics, which are not, they're not universal, but they're frequent. Geographic isolation is one of them, and that's probably more marked in the Pacific, where there's vast amounts of water between each little tiny country. Environments disproportionately affected by global warming, and we all know that small island developing states are at the forefront of the consequences of global warming, which has all sorts of health and economic and environmental impacts. Small populations, particularly in the smaller SIDS, and which limits opportunities for economies of scale. And that's economies of scale at every level. So within health systems, certainly within cancer systems, within government, there's only so many people to do everything. And so there's limited people, there's always going to be limited financial and other resource when you've got a really small population. SIDS often have fragile economies, often based on one or two industries, and that fragility is exacerbated by global warming as well. Limited resources we've talked about. SIDS are also dealing with ageing populations like many other countries in the world, but they've also often got the triple burden of disease. So infectious disease is still a major issue. You've got the sort of tsunami of non-communicable disease here and coming, and also burden of disease related to the effects of global warming. And the other key element of small and developing states is the importance of international partnerships and support. Obviously, international partnerships are important to all countries, but for SIDS, they've often got very strong, they've always got the very strong regional partnerships going on. You see that in CARICOM in this region, and in the Pacific, there's very strong partnerships between the countries of the Pacific, but also very strong partnerships with neighbouring larger population, high-income countries, and also international organisations. So those partnerships are really critical. Okay, so here's a list of the Caribbean countries that were included in the cancer series. Moving on. But in here, very importantly, is a list of the authors that were included from the Caribbean point of view in the Small Island Developing States series. So a few of those people are here. If your name's on there, if you put your hand up, there's a few people I haven't actually physically met. There's at least a couple of people here. Too shy? No? So all of those people have contributed. There's also all of these people who've provided information to us in the work. So a lot of people from around the region have been involved in this work. So cancer burden. Why is cancer important? So cancer is the second leading cause of death in the Caribbean. 1 in 5 of all deaths are due to cancer. This comes at a massive economic cost, primarily due to premature death, but it's also a huge impediment to meeting the Sustainable Development Goals. It's a really big issue. The key cancers in this region, and I'm sure many of you, if not all of you, will be aware of the fact that prostate and breast cancers are very common among men and women respectively. There are very high rates of both those cancers in the Caribbean region compared with the rest of the world, and the reasons for that are not entirely understood. We've also got colon cancer there in the top 5. That tends to be related to sort of dietary factors. It tends to be associated with kind of Western lifestyles. But in addition, you've got cancers that are related to infectious diseases. So you can see in terms of the top 5 causes of death, you've got stomach, liver cancer, and cervical cancer. So those are all cancers due to infectious causes. So this is a bit of a mixed picture where you're getting cancers related to kind of Westernisation, if you like, in combination with cancers related to poverty, infection, still common in the region. And the number of cases of cancer are going to increase, probably markedly. So these are projections from the International Agency for Research on Cancer. The different lines represent different assumptions about what might be happening with the underlying cancer incidence, but the line in the middle is their kind of best guess, the sort of greyish line. And that's looking at the number of cases of cancer that are going to be in the region in the next 20 years. And that's a really steep increase. So there is a lot of cancer coming. And planning for that is absolutely essential. That is Mount Everest. It's not in any small island developing state, but it's a difficult mountain to climb. And I've put that up there because there are a number of myths when it comes to cancer control, and I think particularly cancer control in the setting of small island developing states. And the myths are that cancer's too complicated, it's too specialised, and it's too expensive. And that's why it doesn't make it onto ministers of health agendas, for example. NCDs as a group might, preventing NCDs, which is of course absolutely critical, but cancer control, cancer is kind of lumped in with NCDs, but cancer isn't just another NCD. It is by far the most complex NCD in terms of management. Cancer control includes the entire health system and beyond, and you can't manage cancer without planning for it. And in order to plan for it, it needs to be on the really high up the health agenda priorities. So let's have a look at some of the challenges specifically relating to cancer control in the Caribbean. First of all, in relation to cancer planning and policy, currently only 7 countries in the region have a comprehensive cancer plan, but other countries do have either some cancer-specific guidelines, most commonly relating to cervical cancer, or they have cancer as some part of a broader NCD plan. But still, cancer planning is underdone, and it's also underdone at a regional level. There are incomplete cancer surveillance systems in many countries in the Caribbean, and there was a talk on that yesterday, and Dingle will also be touching on that later. There's some progress in that space. In terms of cancer prevention, NCD control initiatives are very well articulated in the region. So, of course, tobacco use, high BMI and alcohol use are all really important risk factors for cancer, for multiple cancers. So that NCD agenda is really important in terms of cancer prevention. And as you've heard previously at this conference, the prevention policies vary in scope and implementation around the region. So it's a high priority to ensure that agenda is moved forward. But there's also some important cancer-specific prevention activities which are critical. One of them is related to hepatitis B vaccination. So that's actually done pretty well in the region. So most countries have coverage, vaccination coverage of over 80%. Obviously, it takes some time from when vaccination starts to actually impacting on rates of liver cancer, because the children have to grow to the age of where they would have developed liver cancer. But that's an important initiative in terms of bringing down those liver cancer rates. But cervical cancer prevention remains underdeveloped. Cervical cancer is a really preventable cancer, and I'm sure, as many of you know, the World Health Organization, the Director General of the World Health Organization, is aiming to eliminate cervical cancer. And by that, he doesn't mean literally eliminate every case, but bring cervical cancer down so it becomes a very rare cancer. And that's doable. It's highly cost-effective to prevent cervical cancer. Cervical cancer often affects younger women, not only obviously impacts on the woman, but also on her family, on the community. There's a massive economic impact on countries. And yet cervical cancer is still in the top 5 killers in this country for women, cancer killers. So HPV vaccination, even where it's on national schedules, coverage tends to be low or unknown, so the focus isn't as much on HPV vaccination as other vaccinations, and cervical screening is generally poorly implemented in most Caribbean countries, with a few notable exceptions. And by that I mean that there is screening going on, but it's sort of opportunistic, it's patchy, there's not a focus on getting or that the coverage is not high, high-risk women are often missed out, and there's not really high-quality processes throughout the screening process. And if those things aren't in place, then cervical screening tends not to have an impact on cervical cancer mortality. It has to be done well, it has to be, you have to have good coverage and have to have high quality screening in order to make a difference. So this is a really critical element of cancer control in small island developing states. Very similar picture in the Pacific. In terms of cancer diagnosis and treatment, late stage disease is common in this region. And of course, there's a huge variation in the diagnostic capacity across countries in the region. So just an example there, Puerto Rico has 6 times more pathologists than Haiti, despite the fact that it's got a much smaller population. And less than a third of all countries in the Caribbean are able to process all pathology specimens. And of course that has implications in terms of the timeliness of diagnosis and the cost of diagnosis, which is often borne by patients. There are a lot of difficulties in training and attracting specialists. If you were here on the first morning of the conference, you would have heard a speaker talking about how in a small island developing state, you're never going to have a pediatric orthopaedic oncologist, which I think is true. I'm not sure I've ever met such a creature. I'm sure they exist somewhere, but you're certainly not going to find one in a small island developing state, or in New Zealand for that matter. It's difficult when you've got smaller populations to have super specialised care, and for people who specialise to be supported in a way that allows them to practice effectively. And that's because you've got low caseload, so we sort of have to think about different models of care. Having said that, specialised cancer surgical capacity within the region has improved a lot over the last decade or so. But there's still widespread reliance on private care, particularly in the English Caribbean, and that's a marked difference between this region and the Pacific region. If you compare those, there's very little private care in the Pacific, but there's still a lot of out-of-pocket payments here, which means that it's a problem for patients. There are about 70 radiotherapy machines in this region, and just by way of comparison, if you don't include Guam and French Polynesia, which are 2 countries in the Pacific, there are no functioning radiotherapy machines whatsoever in the entire region. So 70, that's quite good, except that 2/3 of those are in only 2 countries. So they're not evenly distributed, nor would you expect them to be, because again, a country with a small population is not going to have the caseload that can support a radiotherapy service. And so there are 16 countries with no radiotherapy capacity at all. So again, this needs a regional focus, a regional planning has to be wrapped around that. So as I've mentioned, out-of-pocket expenditure is high for patients because of unequal capacities across countries, and also the reliance on a lot of out-of-pocket payments. There's unequal access to care both within and between countries in the region. Travelling for care is common, and of course that's common for people living in any small island developing state. But that often comes at very substantial costs to patients and their families. So for patients, a diagnosis of cancer can be financially catastrophic for them and their families. They can end up with having poor quality care, poor continuity of care, and poor outcomes. And then to top all that off, access to palliative care remains limited and patchy, and Dingle will be talking more about that as well. That picture is Sir Edmund Hillary and Tenzing Norgay. Of course, Hillary was a New Zealander like me, and he climbed Everest, so it seemed appropriate. But there's a lot that we can do in the context of small island developing states. So here are some of the key priorities that we've identified, both for this region and for the Pacific region. The top one, and I think the most important one, is getting cancer on the leaders' agendas. Nothing else is going to happen unless cancer is on the leaders' agenda as a specific agenda item, not wrapped up in NCDs generally. That's critical because you need regional planning, you need regional leadership, you need regional resource. Having said that, an ongoing focus on NCD prevention is critical. Strengthening cervical cancer prevention is absolutely essential. Regional planning and procurement. So procurement, we're talking about things like getting cancer drugs, and that happens quite well in this region, much less so in the Pacific. Individual countries are not in a good position to be able to negotiate access to cancer drugs, for example. And then strengthening health systems, which is work that's been ongoing here and in the Pacific, is highly relevant to cancer control. So universal healthcare coverage is really critical when it comes to cancer. Primary care, which is of course the theme of this conference, has a massive role to play in cancer control, prevention, treatment, palliative care across the entire continuum. Health workforce development and support is critical, and also considering innovative approaches to cancer care. So uplifting models of care from high-income countries, or even large or highly populated low and middle-income countries, may well not work in the context of a small island developing state with a smaller population. So thinking about things like telemedicine and telementoring and role shifting and those sorts of things. And we have some more specific recommendations in the papers. And also strengthening palliative care is a really critical priority. So with that, I'm going to hand over to Dingle to talk about some of the innovative things that are going on in the region.
Good morning, everybody, and thanks for coming out so early. Just a brief introduction. I'm Dingle Spence. I'm a Jamaican despite the British accent, and I'm a clinical oncologist and palliative care physician, and have been attempting, as some folks in the room know, to lead development of palliative care in the region. So I wanted to, and I've been working with Professor Sarfati in writing this series, and I was asked to lead a couple of the papers in the Caribbean region on cancer control. So I just wanted to highlight some areas of innovative practice, because, we could all leave here thinking, oh my God, it's a disaster, where should we even start? And as Prof. Sarfati said, it's too much difficult. How do we even begin? So what I wanted to do was just highlight a few areas where we are actually making progress, and gives us some hope for the future, really. So, as we all know, and unfortunately I wasn't able to attend the rest of the conference, I just came in last night, so you've probably been saying this for several days, so I'm sorry that I may be repeating myself, and it's probably similar in all other areas, but just to say it's very difficult, and I can use Jamaica as a case in point, that we're only really just now beginning to collect decent island-wide data. We've had a cancer registry for some years, but it's been very limited to a small area of the island. And so we now have launched a proper population-based cancer registry. So clearly, without data, it's extremely difficult to plan. So one of the really wonderful innovations is the development of the Registry Harbor that came out of the IARC, International Agency for Research on Cancer, which linked up with CARFA and founded the regional hub. I'm probably preaching to folks who know way more about this than I do, but I think that was an amazing development now 4 years ago. And what has happened is that quite a lot of regional training and assessment has happened, helping countries develop their databases in various ways through workshops, through one-on-one mentorship, and really just trying to build a standardized data collection system through the Caribbean, because clearly it doesn't make sense having a different type of registry in each country. We need a standardized one so that we can all come together and look at the data for the region, as including, the small islands themselves. So many things have happened. And one of the many useful things was developing an SOP manual so that everybody has access to that. So even if you are just starting out, you have a way to start structuring your data collection. And then obviously one can start publishing some of that and look at what's going on in the region. So I really highly commend the regional hub in the work that it's doing. And I think it's got to be a fundamental platform from which we look at cancer control, is what's going on in your country, what's the data, how do we collect that data? And for somebody who works every single day as an oncologist with very limited resources, it's extremely frustrating when you can't go to your government with a decent plan because you don't really know what your numbers are. So this is a very critical initiative in the region. And I see Dr. Hospital is in the audience, so just a shout out to you, sir. So then the other thing, again, that's been pretty critical, I think it's only just beginning, but, you know, obviously clinical guidelines are something, and especially if you are very important, and if you're working in an area of high specialization with few specialists, it's really important to have some guidelines out there for the non-specialists who can at least have an idea of where to challenge care, where to refer persons. And whilst many of us in the region in oncology use what's called the NCCN, the National Comprehensive Cancer Center guidelines out of the US, most of those guidelines are written for, obviously, for highly developed countries with resources that we can still only dream about. So what was important, and unfortunately I wasn't able to be present in this initiative, but I think it was 3 years ago in 2016, the NCCN linked up with the Caribbean Association of Oncology and Hematology to look at how we might develop what we call resource stratified guidelines. So let's say, for instance, you're trying to stage a woman with breast cancer. Now, you know, in the developed world, people are having PET scans and MRIs and all sorts of things just for staging. Well, again, we don't really have access to that level. So what's the minimum acceptable thing that you can do for a patient with breast cancer? If it can't be a CT, chest, abdomen, pelvis, and bone scan, can we stratify to the resources that are available and still get the decent information? So this is one of the developments that was happening. So they're called harmonized guidelines for the Caribbean. And several treatment sites have been looked at: prostate, breast, cervical, colon, rectal cancer, lung cancer, and multiple myeloma. And I think one of our jobs is to make sure these are that people know they exist, one, and to make sure that they're disseminated, and to have some sort of basic training for our, not just our specialists, but for our primary and secondary care colleagues, because you're going to see these people in primary care, and it would be very helpful for you to know what basic things can I do before I move them up the chain and refer to more specialized people. So again, I think this is a very promising initiative to help move cancer care forward in the region. Yeah, so I think I've said that really. So then we're going to say a few words about pediatric oncology care. So obviously, again, in the low and middle income countries, and it's ironic really, when I was putting this paper together with Prof. Sarfati, we talk a lot about LMICs, but actually most of the countries in the Caribbean are classified by the World Bank as high income countries. But that actually doesn't equate with the reality of our healthcare systems. So our healthcare systems are much more like low income countries. And I think whilst we have pockets of excellence, I think in general we would relate to the fact that we really do have struggling healthcare systems that are not aligned to high-income country levels. So pediatric oncology obviously falls into an area that's often neglected. And we are moving away from the infectious disease cause of childhood death. Cancer is becoming an increasingly common cause of death in Caribbean children. And again, as Prof. Sarfati said, it's incredibly difficult to develop high-quality cancer care for such a tiny niche population. I will say that we now in Jamaica have 3 trained pediatric oncologists through an initiative I'm going to talk about now. So I'm not sure, what does Trinidad have a pediatric oncologist? Yeah? Excellent. So we're on the way. So this is an estimate put together by one of our colleagues who contributed to the paper about the expected number of new annual cancer cases, and this was extrapolated from data from the Cancer Registry in Jamaica. But you can see, in the Eastern Caribbean, the numbers are small, 3 per year, 5 per year, more obviously in Trinidad, quite a lot more in Jamaica. But how do you manage those 2 kids in, Antigua and Barbuda who have serious advanced malignancy? And clearly you cannot expect an island like that to be able to have a specialist for those 2 kids. So this is really where it points to regional initiatives. How do we come together and facilitate treatments and care of a high quality standard in such a disparate region? But I think, again, there is hope. The way that childhood cancer is financed is very different. So in Jamaica, some is available in the public sector. Often many of the tests are not available in the public sector. So again, we're back to a high out-of-pocket expenditure. There's a lot of philanthropy when it comes to children, so people will often make appeals. There's constant appeals on our TV and in our newspapers for some poor child, and unfortunately they usually come very late. And one of the other problems that I'm sure is common is that many of the parents think that it's what in Jamaica we would say obia, so that this is witchcraft, why my child has a giant osteosarcoma of the leg, and then they won't allow anybody to be involved, because how could medicine fix something that was caused by spirit? So we have a huge problem just getting kids through the door with early stage cancers, much less adults. But obviously it's very tragic when the parents are keeping the children at home until it's very, very late. So when they do come, again, we have limited access to pretty much everything, although the development of having 3 oncologists now is making a big difference in Jamaica. And things that Prof mentioned, access to radiotherapy and consistency of medication supply is a problem. However, there's now a history of twinning networks, and this is something that I think is very important in developing states, that we twin with people who do have the resources and the expertise, and we can have bi-directional information, because they may have often not seen what we're dealing with, and they can support us in education, in treatment, in sometimes taking the kids to the US, if necessary, to more developed centers. So this is a particularly lovely initiative, the SickKids Initiative, which was formed in 2013, which was a collaboration between SickKids Hospital in Toronto and the University of the West Indies and 6 countries in the Caribbean. But again, it's only 6 countries, so it doesn't include the whole of the Caribbean. So if you're not one of those 6 countries, what does that mean for your children who may develop cancer? So what they helped us do was to develop institution-based registries. We have telemedicine education, and they also launched a diploma in pediatric oncology nursing, and facilitated the 3 people, at least in Jamaica, who are trained to get their training at SickKids in Toronto, with some assistance in funding for people having those fellowships. So again, that's magical, because when I started in oncology a while ago, there was certainly no pediatric oncology, and you as an adult oncologist are being asked to manage 2-year-olds with Wilms tumors, which really is not a comfortable position, especially if you're an adult physician. So very welcome, very promising, and I think where we need to be going is to really to look at what is the best way in the region to develop probably a center or 2 of excellence that we can then treat our kids there and then send them back to at least have some decent secondary and primary care support in their own islands. And then the last one I want to talk to, and as you may know, this is where my heart lies very much, is, what are we doing in supportive and palliative care? And really the recognition of the importance of palliative care is just really growing in the region. When I came home from my postgraduate studies in 2002 to Jamaica, it was really, I don't want to say non-existent, because there were people who'd come before me, but there was no consistent palliative care delivery anywhere in Jamaica at that time. And the other thing that's important to say is that community-based care is really one of the the ways we should be thinking about delivering palliative care because of the poverty, because of expensive transport. What happens if you're in the Bahamas and you have an archipelagic nation of 700 islands? How do you deliver decent palliative care? Certainly you can't centralize that in any effective way. So we have to think, A, that we need this service, and B, how do we deliver it over a geographically difficult situation? So I just wanted to mention two strategies. Barbados has an excellent palliative care setup. It's very much community-based. It's run through primary care and public health. At the moment is still run by NGOs. They see between 50 and 60 patients a year. Now that doesn't sound very much at all, but at least it exists. It is happening. And my colleague from Barbados would say there's probably about 2,000 people in the island who actually need palliative care who are not getting it. But the fact that there's a core model that is based in primary care and public health, which can then, I know what they're working on now is taking it from being delivered by NGOs in trying to impress upon the government how important it is to get palliative care into polyclinics so that it's more accessible. So even though it is delivered by NGOs, it is still free of charge to people at the point of delivery. And I also mention Cayman, that has an astounding hospice service. So this is not new, but it's a fantastic model that I really think could be emulated around the region. It was established in 1996, and I must just say, I think one of the things about the islands that are still British overseas territories, and Cayman being a headline one, is that the model from the motherland is able to be translated more, perhaps, in a closer way than it is maybe in those of us who got independence many years ago and have kind of lost touch with those sort of models. So Cayman has a classic hospice model. It's all delivered in the community. They have 2 beds in a villa, but they never have anybody in them because their community care is so good. It is an NGO. Luckily, Cayman is a wealthy, high-income country, and so they can raise all the funds they need to deliver their palliative care, free of charge. They have 3 islands in Cayman, and they manage to do all their care at home. It's led by a physician. They have about 5 or 6 nurses, 3 care assistants, and a host of volunteers. So for me, this is a model that if you you're in a country, so for instance the Turks and Caicos Islands, there's 8 islands that are inhabited out of a 40, I think, archipelagic nation, no palliative care at all. This would be an excellent model, I think, that could be developed in TCI. So I did really want to mention that. And then I wanted to mention, again, as a final note, an initiative that we had in Jamaica. So that's me as a younger version. Myself and our chief dangerous drug inspector were awarded a fellowship some years ago, and the aim was to improve access and availability of opioids in our country, along with people from many other countries. You can see many different flags there. And basically what we found when we assessed the Jamaican situation is that, as I will break into patois here, everybody freed. So nobody wants to prescribe, dispense, or administer opioids. And it took a lot of work over many years. It's still going on 7 years later, or wherever we are, many years later. But we have made big changes in the access and availability of opioids in Jamaica. And just to show you, if you look at the graph there, you can see, you can see 2002. Does this have a... Yeah, somewhere back here. So this is when I came home and started prescribing a lot of morphine. So we had a little jump here. And then the fellowship education and planning kicked in, and this is actually even not up to date. But it's very gratifying to me to see that the increased use of appropriate medicines for the management of cancer and other severe types of pain, in particular cancer pain, was kicked off by us 2 people going off and getting some training overseas. And then also to mention an NGO of which I'm a founder member. I see I'm probably coming up to time. I'm going to shut up in 2 minutes. But again, this is an NGO that I co-founded, and one of our focuses is on training, and we have now run 2 regional training initiatives in palliative care, 2017, 2018, week-long, again with support from our high-income country colleagues. And we think this is a really important initiative in the region, because you can have all the medicines you like in the cupboard, but if people are not trained to prescribe them, they're going to stay there and expire. So where to from here? So I think it's critical that we come together more as a region and share our expertise, and conferences like this are one of those platforms, but we really need to think about how do we bring our data together, how do we find our centers of excellence, how do we move our patients to there without them incurring huge financial burden, how do we get our governments to work together, how do we improve our informatics and data collection, and obviously implementing what we know and what we can do. And I think really for me, we need to do many things, but I think if we actually got our health information technology together, I mean, it is insane in 2019 that we are still writing in paper charts that get lost. And that we have no way of collecting data in a standardized way, and that would make a huge difference to all sorts of health control, but particularly also in cancer care. So whilst we are overwhelmed on many days, there are aspects of cancer control out there that are interesting, exciting, moving forward, and I am hopeful. And thank you to my collaborators.
Thank you, Prof. Sarfati and Dr. Spence. We could entertain 2 questions. Professor Thiem.
Hi, Minerva Thiem from UWI. Minerva Thiem, UWI Mona. Just wanted to make a comment actually to Dr. Spence. You did show the distribution of where the cancers are. We did speak of the SCI and that they were in the 6 countries, but there's a wider reach. It is in the 6 countries, but just to say, because of the network of pediatricians that exists within the Caribbean, I actually know that we have actually moved kids from other islands to Jamaica and to Trinidad for treatment, because that is what the SCI wants to do.